Our next guest speaker is Melissa McConaghy. She's the Director and Principal Physiotherapist of Advanced Rehab Centre, which is located in Artarmon, Sydney. Melissa is a specialist neurological clinician, educator, author, and health entrepreneur. She established Mobile Rehab Innovations in 2006 as an entirely mobile rehab service, and Advanced Rehab Centre in 2009 after recognising the need for a purpose-built neurological rehab centre providing expert rehabilitation for people with complex therapy needs in Sydney. She is also founder of PD Warrior, a program for people with Parkinson's that is taught and licensed internationally, and Insight, an online conference that is part of the global education calendar for people with Parkinson's. Melissa sits on the Clinical Advisory Board for Polio Australia and is the current Australian Physiotherapy Association APA branch councillor. I had to try and not get that mixed up. She is past chair of APA New South Wales Neurology Chapter and a past national representative. Melissa has worked in a variety of neurological rehabilitation settings, both here and overseas, for 20 years, and has taught on a range of topics including intensity in stroke, and contributed to the production of the APA Level 1 Neurological Rehab course. Melissa was awarded Australian Physiotherapist of the Year in 2019 and received Australian Physiotherapy Association New South Wales Branch Council Award for contribution to the profession in 2019. Today, Melissa will be introducing the Lexo, the latest innovation in gait training technology. Welcome, Melissa.
Thanks everybody. Thanks for having me. So I am going to be talking about another robotic gait training device today called the Lexo. So what I sought to do, I come from a slightly different angle because I invested personally in this device, and so I did a lot of research leading up to this purchase decision around what did the literature support. I went over to Austria and had a look at a prototype of the device that I ended up purchasing, and I sought to answer the question, how do we improve walking outcomes post-stroke? And these were some of the issues that we sought to address. So the first one was low step rate. We know in clinical practice, even in a gait training session in conventional rehab, we typically only achieve around 500 steps in a gait training session. Typically low intensity, and we actually audited our own client base. We had heart monitors on our clients, and we did this for a month, and we actually looked at how high people's heart rates were actually going in their training sessions. And we deduced, even though we were pushing people hard, or what we thought we were pushing quite hard, they still were achieving only small amounts of time in a cardiovascular training zone. And that's very common of traditional rehab. It's very low intensity as well. There can be motivational issues if you're trying to get people to do something that's really challenging, really hard, possibly quite frightening if you think you're going to fall over. So there can be barriers to extended treatment as well. It's very labour intensive, particularly if we talk about holding somebody up and then trying to put a foot through a gait pattern. You can often have 3 people working with a person on a treadmill, for instance, which is very labour intensive. The therapists are often very prone to injury themselves, and the individual themselves, they're having a foot moved in space, which can be very disconcerting and can also be damaging to them as well sometimes. It can lead to inefficient and effortful walking patterns as well, particularly if we're reinforcing asymmetrical gait patterns purely because we're too busy trying to hold a person up. We can't actually be exploring what's happening down at the feet and with the weight shift. There can be mechanical joint stresses and pain, which leads to decreased compliance, and plenty of other training issues. And we work with a lot of brain injury clients as well, and often one of the triggers for behavioural outbursts can be that fear factor. They're too busy feeling that they're going to fall over to actually focus on their intensive training and rehab. So these were some of the issues that we sought to address, and certainly some of the issues I sought to address in the purchasing decision that I made. So in terms of looking at the evidence, I thought I'd just draw on 2 very brief examples here. This was a study done by Hornby and colleagues in 2019, and I draw your attention to this because this is one of the first studies that really looked at translation from clinical practice into the real world. And basically the sum of this research paper just basically shows the more steps you can do in gait training practice and rehab, that will typically convert into real world gait training outcomes. And so here they were training people up to 4,000 steps on a treadmill, and that was achieving about a 25% increase in real world activity levels. And that's really the take home message, is what are you doing outside of the clinical rehab setting? That's the most important thing that we wanted to achieve. So we know that high stepping dosage is really, really important. The other thing we wanted to look at is intensity in practice. And I said before, we had our exercise physiologists put heart rate monitors on our patients in our gait training sessions, and we found that routinely people were not achieving any more than about 5 to 6 minutes in a cardiovascular training zone, which means that we weren't really increasing fitness levels of our patients, which means the endurance and the overall capacity to increase their stepping distance was quite poor, even though we were pushing people quite hard. And this is with one of the studies, again, Hornby and colleagues, which supports the necessity for intensity in training. They actually had people looking at self-selected walking velocity, and they had them on a high variable, so working at a really high intensity on a treadmill, but just walking straight, and then they had them walking high variables on an obstacle course, but at a high cardiovascular rate. And then they had a group working on treadmills just straight, and then they had a group walking on an obstacle course and very low, so again, low cardiovascular rate. And the take home from this study is that the group that were both variable, doing obstacles, which you think would translate into clinical practice, and also on a treadmill, it was the intensity, the cardiovascular intensity, that was the key factor to their improvement in walking. And so it's studies like this that show us the two main key factors in improving walking, particularly after stroke, is whether your cardiovascular, your heart rate is up high enough during your training session, and are you doing enough stepping practice. So those were two of the critical features that we drew from the literature and our own clinical experience. And so in our audit, these are just some of the examples of the stroke patients that we were screening. And you can see here on the left here, this gentleman here was hemiparetic on the left. He was using a walker to mobilise. He was walking about 433 steps on average in his training session and only achieving 1 minute in the cardiovascular training zone that would increase his fitness. And we thought we were working him quite hard. The next lady here had a subarachnoid hemorrhage, 340 steps on a treadmill. Very prone to having lots of rest breaks on a treadmill. And of course on a treadmill, even though it waits for no man, she can't stop on the device because it will continue. Very asymmetrical step 2 pattern that is very hard to overcome manually and with a therapist doing that. And no time spent in the heart rate training zone. This other gentleman here who was 6 months post-stroke at the time, 710 steps, so he's actually doing quite well. And he achieved 10 minutes in a cardiovascular training zone. Now we know the threshold for increasing in fitness is 12 minutes, so he's not even there. And then we had this other gentleman here who's ataxic, post-stroke, 2,231 steps. So he's actually doing really well, and he's just achieved the minimum threshold. So this was telling us that in our gait training session, conventional therapy was not working people hard enough, and we weren't getting enough stepping dosage either. So in terms of answering the question, how do we improve walking outcomes, we were looking to robotic devices. It has to be something that's going to improve conventional rehab. And so we looked at bodyweight support treadmill training, which is what we do typically. It's very labour intensive, and it can certainly reinforce a compensatory gait pattern. So then we looked at robotics, and we looked at exoskeletons, which is what Jason has been talking about. There's static devices like the Locomat, basically articulating at the hip, the knee and the ankle. And then there's the assistive devices, which is what Jason's presentation was talking about. From all the literature that we looked at, we surmised that the best device we wanted to go with not an exoskeleton. It was a different type of device called an end effector. And essentially, and my therapy team will kill me for saying this, but it's a glorified cross trainer essentially. Your feet are strapped into the device, and that is what forces a physiological gait pattern. So there's no deviation from a normal gait pattern. It will force a normal gait pattern, and that's what drives the symmetry of gait. We can alter the parameters for step distance, for step length, the speed of walking, and all the variables that can achieve a very, very effective and functional walking pattern. And so we had to basically decide, well, what did we want to achieve with our walking outcomes? We wanted to improve walking outcomes for individuals with functional walking goals, and that's very much suited to a stroke population, opposed to a population who wanted to have the experience of walking. People that are probably unlikely to have functional walking goals or may not achieve independent walking down the track, and I can think of some of the clients that use the Lexo at the moment, so they might have had a paraplegic or an incomplete quadriplegic. They love the experience of being upright. It assists with their bodily comfort levels, bone density, etc., and they just love the psychological experience of being upright and normal again in their experience. But we wanted a device that would really improve walking outcomes for individuals. So from the literature, one of the highest levels of evidence that you can draw from is the Cochrane review, which is a systematic review of as many articles that fit the criteria as possible. And what they showed is that body weight support treadmill training and robotic exoskeletons did not, on the whole, improve the chance of gait independence compared with conventional therapy. So that basically immediately made the decision for us. We weren't looking at an exoskeleton for that reason and many others. The use of robotic end effector gait trainers, which is what the Lexo sits under that category, and rehabilitation for people after stroke, however, did increase the chance of independence at the end of the intervention phase. And that's what we're most interested in. Can we improve independence in walking? And primarily for people in the first 3 months after stroke and for those who were not able to walk. That was the group that was able to benefit the most, and non-ambulant individuals in the acute, subacute phase post-stroke. And then there was a follow-up study that looked at, in comparison to conventional gait rehab, gait training assisted by end effector apparatus leads to statistically significant and clinically relevant improvement in gait velocity and maximum walking distance. So we can improve the distance, the speed, and the independence using devices like the end effector. So I just wanted to show you a brief video so that you can understand a little bit more about how the Lexo actually works. So I'm hoping this will work. Okay, so we don't have audio here, so I will just run through what you're looking at. So it's a much larger footprint than an exoskeleton assistive device. And you can see here, this is James on the device here. It's got interactive computer software that will respond to your movement patterns. We've just had our 100th patient on the device, and I can tell you we've partnered with Macquarie Uni for a feasibility and acceptability study, and the results are absolutely outstanding. Not only do clinicians absolutely love the device, so do patients. And there's lots of parameters that we can explore further. Because we're not so busy holding somebody up, we can actually step back and take a look at what's happening for individuals. Do we want to work on where their foot lands in after swing phase? Do we want to work on how they push their foot through gait? Do we want to work on symmetry? There's all these parameters that we can actually get immediate feedback on because of the sensors within the foot plate, and then we can adjust the parameters to enhance what they're actually doing in their gait training session. So in terms of Lexo Benefits, which is an end effector device, we can certainly increase the dosage of therapy. Our average dosage at the moment is around 1,500 to 2,000 steps. What we underestimated was how much fitness people would need to develop in order to achieve those 4,000 steps. And I think this just speaks to the fact that when you get people on a device like this, which is going to push people really hard, it takes a while for them to build up the strength and the endurance to actually achieve the dosage required. And so for many of our stroke patients, we've actually had them on the device 3 or 4 weeks before they can start hitting that 4,000 step mark, because they need to be fit enough to do it. Most patients will only achieve about 12 minutes and come off completely jelly-legged because they've worked harder than they have for a very long time. So we had underestimated that, but we've had some learnings and takeaways from that. The intensity of practice is quite profound. So again, we've had our exercise physiology team hook patients up, and we can actually look at real time how much time people are spending in that cardiovascular training zone. And for the first time, we are getting people up into that cardiovascular training zone, and they're getting significantly fitter for the ability of this device to actually get them up into that training zone. We can be really precise in our exercise and walking prescription because of the sensory feedback that we get from the foot plates. We can adjust immediately and in real time the parameters and the feedback that we give to every individual to make sure that we enhance their experience on the device. It's incredibly motivating. We actually struggle to get people off. If they're not completely exhausted, they don't want to get off. We have to physically pick them up and move them off. And I think, again, that's a factor of the gamification that comes with the computer interactive software. And I think the fact that you come off and you immediately have an increase in symmetry because you've just been forced to do that for the last 20 or 30 minutes. You have this carryover effect of symmetry, increased stride length, lack of gait, reduced gait variation, and people just love the experience of being able to walk better. And that carryover can be very variable for some patients. It can be 24 hours. For some people, we've had it 4 days. But then they'll want to come back and build on what they've learned and practiced previously. And certainly the decreased injury risk. Our use of the Lexo is down to 1 clinician per patient on the whole. Sometimes we might need 2 therapists to get a patient on and off, particularly if there's an incomplete quadriplegic involved. But there's no labour involved from a clinician's perspective, so it's no longer self-limiting to how long I can actually physically move a limb through space, which might be one of the reasons why we only achieve 300 or 400 steps in a session. And the patients are basically harnessed into the device. There's nowhere they can go, so they feel very comfortable and very confident in the device itself. It's incredibly accommodating. We can take people up to 6'6", up to 200 kilograms, and we've just had our little bitty cerebral palsy 8-year-old who was 15 kilos on the device as well. So it's incredibly accommodating for spasticity and contracture. We've had a lot of patients with fixed AFOs on the device quite comfortably. And I think that's all that I can tell you from that. And it's got an active mode, a passive mode, and an active assist mode. And again, some of the features that we underestimated was that passive mode. So that would actually force you to take a normal stride length with normal symmetry, etc., take your weight. We underestimated how significant that would actually be, and what we can do is force that normal gait pattern and then use those sensors to get that feedback and say, right, I really need you to focus on your heel strike for this bit, and you'll get immediate feedback about how well they're hitting the mark. They get really big smiley faces, which we use for the paediatric population, and then you get different colours depending on how much weight you're actually putting through that heel, for instance. And so we can change the feedback that we give to the client based on how they're performing. So I won't go into this too much. I think some of the main considerations are not uncommon to what Jason mentioned, which can be range of motion. It can be incredibly accommodating for contracture, but not for all. Spasticity, at the moment, we've not excluded anybody for reasons of spasticity or clonus, and we've had some brain injury clients, MS clients, and spinal cord injury clients with significant spasticity that have managed really well and actually improved because of the experience. Trunk control to a degree, the harness will come up to here, so anybody without head control would probably struggle on this device, but anybody without trunk control to a point, we can be fairly accommodating for. And then I think cognitive and psychological problems or psychiatric problems might be one of the limiting factors as well, which is something that we triage in the assessment. What are the goals? Is it a functional walking goal? Because that will dictate how much training is required. Usually we're trying to drive neuroplastic change, which basically means how we drive the efficiency of pathways within the brain. Usually we'd recommend 3 times a week to actually achieve those gains. So a quick block, maybe 4 weeks of 3 times a week, will probably achieve the best outcomes. And then if we can extend that even longer, even better outcomes. And then obviously just monitoring for comorbidities. They are in a harness, so we need to make sure that there's no sensory disturbance or catheters that we need to accommodate for as well. We do it as part of our overground walking practice as well, because again it goes back to translation of clinical practice into overground walking and making sure that when people come and use the Lexo, they can take that learning home with them as well. So the only device in Australia, the end effector, can achieve 3,000 to 4,000 steps in a training session, which I think is profound. We've got much more capacity for time spent in the target heart rate training zone, so we're getting people a lot fitter than any other device we've seen in Australia at the moment. Single therapist for setup in training on the whole. It's a responsive gait pattern, so we can actually refine your movement pattern to be more of a physiological and normal walking pattern. Variable body weight support, so we can reduce a lot of the load if there's any biomechanical joint stress or pain, and very few safety concerns and increased patient confidence. So we're very, very happy with the device. As I said, we've just had our 100th patient on it. We've got some data that we're pulling together, and we'll be able to share that at conferences coming up. So if you're interested in finding out more about the device, you can email me directly. Thank you so much.
Thank you, Melissa, on a very interesting Lexo presentation.